of Medicine podcast with me, Dr. Amie Burbridge.
And me, Dr. Ben Lovell. Nice to see you again, Amy. It's been a
Lovely to see
while.
you too. It feels like it's been ages, and
Too
I don't
long.
know why it's been so long. I think it's a combination of winter pressures, maybe at work and life.
Hmm.
But we are back on it. So we're going to be back to 2 episodes a month.
Yes. New year,
Great.
new us.
Excellent. So I've got a case for you today, Ben.
Yep.
And actually, I am going to take you back to when I was a registrar.
Hmm.
Obviously only a few mere months ago, if
Yeah,
only. But it was a
absolutely.
lot longer ago than that. And the reason I'm going to talk to you about this case is when I was thinking today about what we should talk about, there are so many cases I've seen recently that I think they've got some really good learning points. But this case sticks out as one of the key cases I saw during my training for many reasons, but it also impacts how I practice every single day at work now. And when we get to the end of the case, you'll be like, oh, I understand now. That's why you do this.
That's
So
why you're the way you are.
that's why you're the way you are. Exactly. So it was a night shift, and I was working in a small district general hospital. And there was only one registrar on overnights then. And it wasn't very busy on call shift. It wasn't a very busy take. I can't remember how many people I'd seen, 3 to 4, but it wasn't huge and it wasn't chaotic, which it often feels like it's now. And a 47-year-old female was referred to me from the ED department, and she was normally fit and well. And her presenting complaint was some grumbling abdominal pain. Any thoughts? 47-year-old grumbling abdominal pain.
Well, God, take your pick. Okay, working through the systems. This is a
Yeah.
GI issue. I know
Hmm.
nothing about the location of the pain. You're going to tell me about it, but I start thinking, is this something related to the GI system, to the gut? Is this something related to the gynecological disorders? Is there ovarian? Is there anything like that?
Hmm.
If I was Amy Burbridge, I'd say, is she pregnant? Because
Hmm.
you always like to check that. 47, it's not unreasonable. Rarer cause of hepatobiliary causes as well. Is it a biliary colic? Is it more renal angle and it's pyelo? Is it
Hmm.
really neuralgic because it's shingles and it's a skin problem? I've missed about 10 other potential causes of abdominal pain, but at the moment, my surgical sieve is wide, wide open.
It could be anything, couldn't it?
Yep.
Absolutely anything. And she was in a cubicle, and I walked into the cubicle, and I had another doctor with me, a trainee doctor. This woman looked incredibly well, and she was sitting on the trolley, looking really well, chatting to a friend who she was with. And I was like, oh, it's the middle of the night. Why is she in hospital? She looks really well. You know, if I felt well, I wouldn't be in hospital. And you have all this sort of conversation in your own head. So
Yeah.
asked her about the abdominal pain, and she said she'd had it for a couple of days. The pain was all over the abdomen, but more located towards the right iliac fossa.
Okay. Yeah.
The pain didn't necessarily alter with movement, and she did, however, feel a little bit nauseous and she'd vomited a couple of times throughout the day. The pain she graded as 6 to 7 out of 10. And I said, if 10's the worst pain in the world you've ever had, zero's no pain. And she was like, yeah, it's about 6 or 7. But she didn't look like it was that bad. And however, she had had some pain relief while she'd been in A&E. She said that her bowels were working okay. Her bladder and her urinary system was absolutely fine. And she denied a fever, although the day before she felt a little bit hot and sweaty, but she hadn't checked her temperature. And certainly at that point, she didn't have a temperature. She also said that her appetite was a little bit off and she just didn't feel like her normal self, felt a little bit tired, felt a bit weak, but it was quite non-specific. So 47-year-old, generalized abdominal pain, worse in the right iliac fossa, a little bit of nausea, no bowel problems, and no urinary symptoms. I wasn't worried. She looked well. Any thoughts?
I mean, she's got a tummy ache at the moment.
Yeah.
So, the cause a multiple. I'm thinking right iliac fossa. Okay.
Mm-hmm.
What lives in the right iliac fossa that can hurt? You've got an appendix there. That can go wrong. You've got the beginning of the large bowel. You've got the ileocecal junction, and you've got the beginning of the ascending colon there. Colitis, that can cause pain that goes down there. Some people have ovaries and fallopian tubes down there, and they can have all sorts of problems with those, inflammatory, related to pregnancy, related to malignancy. So they'd be my main things. So I need to get my hand on an abdomen, have a feel, see what it feels like.
Yeah.
And that would guide me towards what kind of investigations I might like in terms of bloods and imaging.
Yeah, absolutely. So further on in the history, I asked her past medical history. There wasn't really anything of note. She wasn't taking any medications. She had no past surgical history of note either. She wasn't allergic to anything. There was no family history of anything. She worked as a teaching assistant in the local school, was a non-smoker, drank a little bit of alcohol, but just normal amounts of alcohol, wasn't an excessive drinker, and no more concerning features in the history, really. She denied chest pain. She did feel a bit short of breath, but again, I didn't really think too much of that. She denied chest pain, as I said. She had no pain in her calves. That was concerning. She did feel generally a little bit achy, and I was like, ooh, abdominal pain, a bit of ache. Is this like a gastric type flu? Is this appendicitis? Is what you suggested? So I examined her abdomen and I felt a pulse, and her pulse was around 110, 120 beats per minute. So she was tachycardic, and I was like, ooh, this is slightly more worrying. Her blood pressure was around 110 systolic. So I guess you could say it's a little bit on the lower side, but I didn't know what her normal blood pressure was at the time. She looked a little bit pale in the face, didn't really look in pain though. Chest was clear, heart sounds were normal. When I examined her abdomen, she was incredibly tender in the abdomen, all over, but particularly in the right iliac fossa. I guess you could say that she was guarding. Bowel sounds are present. My first question was, why on earth has this person been referred to the medical team? Because it feels like this is a very, very surgical abdomen.
Fair enough. I mean, based on the information you've given me now, I probably would be doing a CT scan.
Yeah.
And I'd be writing on the request, right iliac fossa pain and guarding query appendicitis. I think it's a
Yeah.
reasonable punt at this point. A
Yeah.
couple of other points you've said. The nausea and vomiting, vomiting a couple of times. That's a pinkish flag, not a red flag.
No.
But you tend not to vomit with conditions such as irritable bowel syndrome. In fact, you don't, in my experience. So that does point towards pathology. Pain being 6 or 6, 7 out of 10. I went back to the drawing board actually with how I regard pain a few years ago when I had to have major surgery myself, and I was very struck at post-operatively how I would say I'm in terrible pain, really agonizing pain, and I'd be met with well, people aren't usually in this much pain after this operation, so let's see how you go. And also, what was the other one I got? Well, people usually aren't in this much pain after they've had this oromorph, so I'm not quite sure. And I thought, goodness, well, I'm sorry, I'm an outlier, but all I can say is I'm in terrible pain. Would you like a number? 8. That's quite bad, isn't it? And I sort of, instead of saying I'm judging your pain now, I sort of say, well, whatever the patient says is their pain, I'll just say that's your pain. I'm not going to say, nah, I'm downgrading you. You say 8. I think you're more at a 5 actually, because you just don't know. And people with lots of conditions who are unfortunate enough to have chronic pain or have flare-ups of pain, and I'm thinking about things like sickle cell disease. They do all sorts of things to try and distract from pain, which includes scrolling on your phone or talking to people or playing games and stuff that we look at and we think you shouldn't be doing that if you're in agony, but this is their pain coping mechanism. So I've kind of thrown out all my old ways of saying, well, they say they're in this much pain, but I've got to say they don't look like they are to me. And I just take it at face value now. So she's saying she is in significant pain. So let's do a pregnancy test. Let's get some blood. The CRP might be elevated if she has appendicitis. And I think there's enough evidence here to do some cross-sectional imaging. I think most people would do a CT scan. I know some centers prefer ultrasound if they have it, but I doubt you'll have that in the middle of the night.
Exactly. So you're absolutely right. So I didn't do those things. And I don't know why I didn't do them. So I didn't do a pregnancy test because she was 47. And at the time I was younger and I was like, she can't be pregnant at 47. I mean, do people have sex at 47? Yeah, I know. Can you believe that I thought that? And I was like, and she must be obviously going through the menopause. And now I'm approaching that age. I'm like, okay, so I would certainly have reframed my biases about that. I mean, it's a massive bias that I had then. So we did some blood tests, and the hemoglobin was around 80.
Low.
Low, absolutely. But our MCV was normal, so it was almost like it wasn't like didn't fit the picture of a chronic anemia anyway. Her kidney function was normal, her liver function was normal, her CRP was elevated around 150, 160. So obviously there was some inflammation there, and there was a drop in the blood. And we didn't have any previous blood tests, so I didn't know whether this was an acute drop or a chronic drop. In addition, her white cell count was elevated, 20-ish, and her neutrophil counts were high as well. Okay. So that was the information that I had. We didn't have any cross-sectional imaging because this was a while ago, and actually the availability wasn't as good as it probably is now.
Mm-hmm. Oh, I remember when I was a registrar, you didn't get many CTs overnight. You parked the patient until they opened at 9 a.m. I remember that very clearly.
Yeah.
So I'm struck by the raised CRP and white cell count. Again, I think we need to rule out an acute abdomen. So I'm still going to be pushing for the CT scan. I probably would, even in the absence of a fever, be giving some antibiotics at this point as well, because my differential diagnosis includes appendicitis. Now the anemia, the normocytic anemia with an HB of 80, was the rest of her full blood count normal, platelets?
Normal.
And you've mentioned the white cells were slightly elevated. So a normocytic anemia, usually with iron deficiency anemia, as you know, you get a microcytic, although you can get a normocytic anemia. So I still would add on iron studies, knowing I'm not going to get those results, within my shift time, but it's something that
good thoughts. Yeah.
And I also, when someone has a normocytic anemia now, I always look at the red cell distribution width. Do you do that?
No, please remind me why you do that.
So it's on your full blood count. We tend not to look at it. It's the RDW, red cell distribution width. And what that says is how big on average are you, what's the standard deviations of the size of your red cells. Someone might have a normocytic anemia because they've got a mixed microcytic and macrocytic problem. Yes. You see this in older adults who have iron deficiency and P12 deficiency. So they've got a normocytic anemia, which throws you a bit. But then you look at the red cell distribution width, and it's like 20%, should be, I think, less than 15. And that implies you've got a lot of cells that are big and a lot of cells that are small. And it points to two pathologies. So I do look at the red cell distribution width when I see a normocytic anemia now and just say, is this because they've got a microcytic and a macrocytic pathology? If that's normal, the red cell distribution width, then I'm like, okay, these are normal sized cells. And then you start thinking about anemia of chronic disease. So if she was bleeding from somewhere, for example, let's say menorrhagia, I'd expect it would be microcytic, unless she was hemorrhaging acutely. The other thing is she hemolyzing? But you say her bilirubin was normal. If I really thought there was a acute hemolysis, I might look for haptoglobins and an LDH.
Yeah.
I can't really see why she should be hemolyzing at the moment. That would be an odd thing to happen. So yeah, I can't quite explain that HB drop at the moment. So I'd need to get the hematinics and have a think about it.
Yeah, absolutely. And I looked at the blood tests and I thought, well, she must be septic. Because obviously she must be septic because everyone was septic. And it was just, I felt like it had been programmed into my brain so much through training that a raised white cell count, raised neutrophil count, a tachycardia, a slight hypotension, it must be sepsis. Must be sepsis.
Well, there was a phase of that.
There wasn't there?
How old were we when SIRS was a thing? I'm sure I was a reg.
We were registrars, and I
heavily promoted. SIRS. If they've got SIRS, think sepsis. And SIRS was 4 criteria. Gosh, I wish I could remember what they were. One was a raised white cell count.
It was.
I think one was a raised heart rate. But SIRS, it was a systemic inflammatory response syndrome. And if you had SIRS, you may have had sepsis. You had to think sepsis. That was the campaign, and look for an infection. Other causes of SIRS was like pancreatitis, anaphylaxis, trauma. But you had to think SIRS, and that seems to have gone now. Does people still
It's
say
not something
SIRS?
I hear very much anymore. And do you
No,
remember we used to do the SOFA score and the Q SOFA score?
that came after. First,
Did
it
that
was
come after?
SIRS. There was a ladder. It was SIRS plus infection equals sepsis. Sepsis plus something else was severe sepsis. Severe sepsis plus failure to respond to fluid was septic shock. It was a
Yes.
really easy cognitive schema to learn. And then I think they threw it in the bin and said, whoops, we've misrepresented sepsis entirely.
Sepsis.
Let's go for the Q SOFA, which was 3 features.
Mm.
And now where do we stand with sepsis? I'm not entirely sure. I know
No,
we
and that's a really
think
good
sepsis,
point. Yeah.
but
There's been sepsis, isn't there? And
there's
you
not a
still have
tick
the
list.
sepsis. Yeah. But I remember it was so vivid everywhere. There were images everywhere. It was almost you observed it via osmosis because it was sepsis, 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 which is
Yeah.
absolutely the right thing to do in a way because we do miss sepsis still, and it's so important that we think sepsis and that we recognise sepsis and we treat it.
Mm,
However, I think what it did with me was it stopped me thinking of anything but sepsis.
okay.
So I think I sort of went the opposite way. And I've heard this from other clinicians I've worked with as well, is because we talked about sepsis so much that all hypotension, tachycardia, high heart rate, high respiratory rate, raised CRP, white cell count, raised lactate was sepsis
Yeah.
until proven otherwise. And actually, that wasn't the case. And actually, thinking about sepsis, I did do a blood gas on her, and her lactate was elevated. I can't remember how elevated it was, but it was a little bit high, and she was a little bit acidotic. So I guess that's why I went down the sepsis picture, and I gave her fluids, I gave her antibiotics, and it's like, right, great. Oh, she's going to be fine. You know, I've given her a bit of pain relief for the pain that she's in. Not really sure what's going on. There's not much I can do overnight. You know, I'm going to give her some fluids. I'm going to give her some antibiotics, some pain relief. Okay. And then about 6 o'clock in the morning, I was called to see her again because she wasn't very well and she started to look unwell. And she complained of more abdominal discomfort. So I upped my pain relief on that pain ladder from paracetamol and I might have given her something a little bit stronger. And she started to complain of pain in the shoulder tip.
Okay.
And I was like, and what does this mean? You know, I have no idea what this means. It means your diaphragm's irritated. Have you eaten something? Have you got hiccups? Is it the medication that I've given you? I had no idea. No idea. Any thoughts going through your head?
Yeah, diaphragmatic irritation. So now has she got something cooking in her belly,
Yeah.
her abdominal cavity?
Yeah.
Something's hot, something is churning out CRP, something
Absolutely.
is making her tachycardic, something
Yeah.
is now irritating her
Yeah.
diaphragm, and she's getting referred pain to the shoulder tip, to the sort of C5 area. So has she got an abscess? Has she got a collection of some kind in there? So it all points towards the need for a scan, really. And I would, and at this point, there was no antibiotics on board, right?
No. Well, I had given her antibiotics because of
Okay.
the
Oh,
sepsis.
because you thought sepsis. Okay.
Yeah. But she was sick. And I thought, okay, this must be an acute abdomen. Exactly what you thought.
Mm.
And still couldn't do anything, as you know. I still thought, okay, I'll give her some more pain relief. I'll speak to the surgeons. Let's speak to the surgical team now. I really think I need to get them on board. And eventually a surgical doctor came down and said, yeah, this must be seems surgical. And we will see her and scan her, and but Steve, keep her under medics. And then you keep an eye on her, and then we'll see what happens. And I was like, okay. And I felt reasonably sort of appeased by that, and I was like, I'm finishing work soon. The pain's a little bit better. She looks dreadful, but the surgeons are here. I'm still not quite sure why she's complaining of this shoulder tip pain. And I went home. Didn't think anything more of it at all. Until about a couple of weeks later, I got asked to a senior incident group meeting with a number of people within the hospital to discuss the case. And I was like, but what did I do wrong? I referred to the surgeons. And there was a lot of things I didn't do that I could have done, and I certainly do now. But it appeared that the shoulder tip pain was the key factor in this history that I'd missed. And absolutely what you say is there's some intraperitoneal collection that was irritating the diaphragm. and the nerve distribution was exactly the same for the diaphragm, and it refers the pain up to the shoulder tip. And my understanding is that is from embryological origin, and how we originate is that we share that same sort of nerve distribution. And it appeared that she'd had an intraperitoneal bleed. There was a huge amount of blood in her abdomen. So they took her to theatre, and this turned out to be a ruptured ectopic pregnancy that I'd missed.
This is like your origin story, Amie, because
This is
how many years have we been talking about the importance of doing a pregnancy test?
why do I do it? And do you know what's really funny? At the beginning of this, you said, well, because you're Amie Burbridge, you will ask, is she pregnant?
Yeah.
And this is why.
And you would now.
And I would. And I remember sitting in this meeting, and I remember who was there. I remember where the room was, and I remember how we were sat. I remember pieces of paper being on the table, and we were talking through the case. And it hadn't clicked. I still, for some reason, I hadn't thought about the shoulder tip pain, and she was 47, so she couldn't be pregnant, and all of these bias going around in my head. And she was really sick, and she could have died. She didn't. It was picked up, it was operated on, and she was okay. But my God, I missed it. I messed up. And that's exactly why I do a pregnancy test on every woman I see, within reason.
We've talked about a lot about it on the podcast about previous case or recent case bias and how it affects you going forward. And it can affect you in two ways.
Yeah.
You can learn from it, and it actually makes you a safer doctor moving forward because you think, I'm never making this mistake again. But it can also go bad, and it can fester, and you can actually subject patients to unneeded or sometimes inappropriate investigations and scans because of your previous case bias and the wound that you're carrying with it. Completely anonymously, I know a consultant who did a lot of CTPAs for chest pain. And I remember that because I was the reg who had to ring up and request them. And it was always a battle because radiology was saying, what? Why on earth would you want to think this is a PE? In some cases, the D dimer is negative, or it sounds cardiac. But that consultant was carrying a previous case bias where they missed a PE, so everyone got a CTPA. And I argued that's how it can go wrong. You don't want to use money, financial resources doing scans that patients don't need. You don't want to subject patients to radiation that they don't need, or the stress and anxiety of having a scan and thinking they might have a blood clot, which is a scary phrase in lay terms. So just in that one example, it sort of shows how it can go the wrong way and you actually do the wrong thing. So how do you make sure, us two and people listening, that when you do have a situation like this, which is going to happen and will happen to all of us, how do we make sure our previous case bias makes us safer and more competent doctors moving forward and doesn't make us the other kind who are fearful and are doing too many tests or the wrong test or over investigating?
I still haven't got that correct. In this particular situation, because the investigation I was doing more of was a very quick, simple pregnancy test that had no impact on the patient. So, because I say every woman is pregnant until proven otherwise, and I will ask for pregnancy tests, it actually doesn't cause any additional harm to the patient. I'm not exposing them to radiation. I'm not exposing them to unnecessary blood tests. If I'm dipping the urine anyway, if I dipstick it for a pregnancy test, doing a beta HCG in the urine, then actually it's not necessarily causing them harm. However, is this going to be causing significant cost burden to the NHS? Probably not. It's not necessarily an expensive test. But you're absolutely right. How many cases have I missed on this in home medicine? How many MIs, PEs have we talked about that we haven't picked up on? But what is it that stopped us from completely over investigating? And a lot of it, I think, is the value in reflection, and a lot of it is through sharing on the podcast, but also at work, sharing with colleagues and saying, I can't believe I didn't pick this up. reflecting, talking about it, and having that mutual acknowledgement that we all do because we're human. And if you work in an open, honest environment at work where you share your mistakes as well as when you do things well, then we're working in a safe psychological space at work within our team where we're not scared to talk about this. And everybody within my team is happy to say, hands up, I didn't think of that. Whereas if I was in a team where everybody was like, I've never made a mistake, I'd probably be much more cautious and maybe do more tests. And so I think it's multifactorial.
I think to add to that, talking about mistakes you've made is important because it's sort of role models that everyone makes. And one thing I always really like about the SAM, the Society of Acute Medicine Conference, is that we often have really amazing sessions where consultants talk about a case I've made. I've been to a mistake I made. I've been to loads of conferences and they have this very inspiring session saying about cases I managed really well, or really fun case. And we do it here on the podcast, cases that we did such a great job on. Fine. It's very rare you have people saying a case where I messed up and what I learned. That takes a lot of vulnerability and honesty, which, but I find it tends to be the one that gets people buzzing, in the coffee sessions
Yes.
to the conference.
Yeah.
People are like, did you see that last? That was amazing what they said. And I find that it really impacts on people, just showing, hey, look, this is something that I got wrong once.
Yeah.
So I think role modeling, not knowing, we've talked about that a lot, and also talking about mistakes in a suitably anonymized way. And what we learn from them, I think, is very powerful within medical education and is only just being recognized and embraced because historically we work in a profession where you did not publicize your mistakes because you wouldn't be hired or you even get sued. There was a lots of negative outcomes for it. So that's one thing I would say. The other thing is we work, all doctors, but us, treating new patients at the front door of the hospital, we work in risk. And in human factors, there's something called the perfection myth. And the perfection myth is that if you really, 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 really concentrate and you work really, really, really hard and you think really, really deeply and you really put your all into it, you'll never make a mistake. And we know it's a myth because that's simply not what human beings are programmed to do. That's not what we are like. And we have to know that we are going to make a mistake because we work in risk. We don't work in absolutes, and we're often making judgment calls. We say this to patients all the time. We say, the risk of your having had a heart problem is very, very low. So low, I'm happy to discharge you today, and I don't think it'll be a problem. But we shy away from saying, there's no way this was a heart problem. They no, go home, you'll be fine. Because we know we work in risk. All we can do is call the odds as we best calculate them. And once we accept we work in places where we're balancing risk, then we must accept, ergo, that we're going to get the risk the wrong way around and we're going to make mistakes. It's part of the job. It is part of the job to make mistakes because we're balancing risk.
Yeah.
I was never taught that.
Me either, ever. And I think that's why this case affected me so much, is because I was like, oh my God, I've really, really messed up here. I was embarrassed about it. There's a lot of shame surrounding it. And I did learn a lot from it, not about myself really, because at the time I didn't really do much self-reflection. I just probably blamed myself and went, I'm never missing that again. Everybody's having a pregnancy test. I'm going to carry around a pregnancy test with me just in case there's not one in the hospital. I ever need it for a patient, which is absurd really. But you're absolutely right. And this week I had a conversation. I was working in ESDEC, which at the moment is incredibly, incredibly busy. I don't know how many patients I see and how many decisions I make on some days. And I was saying to somebody, we balance risk all the time. And I might see 30 people. I might send home 28 of those people. And I will have made a mistake in one of those. Just through probability, I'm not going to get 100% of things right.
Yeah.
But also, I can't also admit all those people and do loads of tests just in case I'm worried about missing something.
Yeah, exactly.
And I remember having a conversation with 2 patients this week who had quite non-specific symptoms. I didn't really know what was going on, but they were well, they looked well, observations were fine. And they were like, well, what's the cause? And I was like, I really don't know what it is, but I know what it isn't. So I know that you haven't had a heart attack. I know that you haven't had a blood clot in the lungs. I know that this isn't pneumonia, but I don't exactly know what it is. but I'm happy that it's nothing serious. And it's really hard to have that conversation because some patients like, okay, I'm happy with that. And some patients like, but I want to know what it is. And that's when we get into the realm of giving patients a diagnosis just to make them feel better, but actually it's not real. We send them home with a label of gastric esophageal reflux disease and maybe a PPI, but they don't have it. But they wanted a diagnosis. They weren't happy with the uncertainty. So here we are, go away with water. And oh, it just makes you feel uncomfortable.
I make the diagnosis of costochondritis so much in our aesthetic because we get all the chest bones referred. I actually have a printout stash. I printed off what is costochondritis. Here, read this and go home because they don't want, and I get it. I wouldn't want a diagnosis of non-cardiac chest pain. What is that? I mean, that's an anti-diagnosis. You know, they want something else that you can tell your mum or your husband when you get home what the doctor said. So I do get it.
I get it. It's yeah. And I've noticed that I'm sort of because I'm seeing so many people now, I'm often having more conversations about I'm not sure what this is, but I know what it isn't. Whereas if I'm seeing 10 patients in a day, I feel like I can take a history. I feel like I can approach it a lot differently. And I feel like I'm balancing a lot more risk now than I may have done 10 years ago.
And as a final point, I will say that it is a source also of job pleasure and satisfaction balancing these risks. It is
Yeah.
what I am paid to do, and it requires a heck of a lot of training and a lot of experience to do it. And I am, you know, in my way, I'm privileged to get a chance to do that and to make the ultimate decisions, the buck stop decisions, based on how I call this risk based on all the evidence I can see in front of me. And I'd hate people to listen to this and go, this sounds awful. I would hate to be a consult me. Balancing risk, that sounds dreadful. It actually is a source of job satisfaction as well. I just to throw that in.
Yeah, absolutely. And you get a sense of enormous pleasure and like, oh, I did a really good day today. You know, when you have had a day that you feel like you've really like you've nailed it. Not that it happens very often, but when it does, I'm like, oh, that was really good. So the key takeaway point for me today from this podcast is any woman is pregnant until proven otherwise.
Thank you very much. We
Thank
knew
you.
that. We knew that anyway, because you say it on a semi-regular basis, but now we know why.
Exactly. Thank you so much to everybody out there who's listening, and we'll be back soon. Goodbye.
Bye.